we can get a prompt and accurate diagnosis for our patients. And it's also good that we have a good level of knowledge on the laboratory values that we're running every day. If our vet is busy in a consultation and we have a critical patient in front of us, we shouldn't be ideally just printing off those results and waiting for that vet. We should be interpreting those results and having a look to see actually what's going on with our patients. And that will just allow us to be able to implement a quicker and more effective level of care to our patients, particularly those who are sick. Now, there's a couple of different areas that we're going to talk about. So we've got sample collection, common in-house tests, renal and hepatic. We'll talk briefly on urinalysis and then a small section on blood smears as well. Okay, so we're all RVNs. I'm not going to sit here and talk to you about how to take blood samples, but there are just a couple of hints and tips and a few take-home messages that we can utilise and tailor for our individual patient needs. So a jugular sample is the preferred method. It is straight from a central vessel and it is great for our larger volumes. I know that many people do still refer immediately to the leg or the peripheral vessel, but if you can, the jugular vessel is the preferred method, and it is quite easy once you get used to it. Now, there are some contraindications, so I have coagulopathies written down here. That's if any patient seems to have a blood clotting disorder, or maybe you don't have a diagnosis of a clotting disorder, but the patient's in with something like epistaxis, a nosebleed. Maybe you've noticed some areas of petechiation or pinpoint bleeding, maybe on the gums, the sclera of the eye, or down the midline of the abdomen. And if you do suspect a coagulopathy or a clotting disease, then we need to tread carefully when we're looking at the jugular vessel. And those cases, we would go for a peripheral vessel in the leg. And also if we have any signs of head trauma, then we don't want to be raising that patient's head and occluding the vessel, which will increase that pressure above the vessel and increase that intracranial pressure. So for these patients, the peripheral vessels are great. They're good on a daily basis for small volumes, and you can take samples from an IV catheter if you have to. It's not ideal, and I'll tell you why in a moment. But if you have a patient who's maybe doesn't like to be handled or is a little bit tricky, then you can always take blood from the IV catheter if you need to. Now, if you are going to do this, just don't do it too quickly. So the amount of times I've seen people applying such negative pressure to that syringe that the blood is almost bubbling when it's coming into the syringe. So that's going to destroy a lot of our blood cells. So we don't want to see that. And we just need to be careful that we are being cautious with this sample and we don't aspirate too quickly or we're not too rough with it. And ideally it should only be when you place the IV catheter. If it's already placed, we shouldn't be going back to that IV to try and get further samples. And then finally, I don't know how many of you place or nurse patients with central catheters into the jugular vessel, but if you do have any critical patients and you work in maybe a hospital or a practice which has overnight care, then a central catheter can be ideal for the more intense patients and those that may need multiple blood samples taken, such as a diabetic patient, a DKA patient. And if you need large volumes or frequent volumes, you can do it all without disturbing the patient. So it's a great resource to use. Now, this is just a little take-home message, a reminder that we should always fill the blood to the marked line, because if we don't, particularly if we're doing a hematology, then it can cause the cells to shrink. If we're sending that off to the lab to look under the microscope and analyse those cells, we don't want any alterations that could alter our patient's results falsely. And you can get abnormal hematological results as well if you're doing a hematology and it hasn't been filled to the line. It may well throw out some abnormal results on the machine. And finally, just always remember to fill the EDTA tube last. And the reason for that is because the anticoagulant within the EDTA tube is made up of potassium salts. So even if you don't touch the inside of the tube, but you hover close to it I've seen the results be affected just by hovering close to the inside of these tubes. And the potassium will be falsely elevated, and it also collates the calcium, so the calcium will be low. So that's a hallmark sign of possibly someone has actually touched EDTA rather than our patient needs treatment for a hyperkalemia, a high potassium value. So always question that. If you're not expecting a high potassium value, yet you've seen one on the results, always check with the person, have they filled the EDTA tube last before we act on that result. Okay, so we'll talk briefly about urine. So we have free catch is the most natural method. You can do many different tests from this, whether it be your specific gravity, your dipstick. It should be collected in a sterile kidney dish, and we should always be going for a midstream sample. One thing to stress is this type of sample is unsuitable for culture. We should not be culturing a free catch sample. There's bacteria on the prepuce or the vulva. It's maybe passing through fare on the way out. And even if it is a midstream sample in a sterile kidney dish, there's no way of guaranteeing that the sample is sterile. So ideally, if you do culture one of these samples, you won't know whether that bacteria is from the pot you've collected it in, whether it's from the prepuce or whether it's from the bladder itself. So it's inaccurate. We could also place a urinary catheter as another option. It may be traumatic, although they do seem to tolerate this quite well. It's contraindicated if we're suspecting a urinary tract infection, so we wouldn't want to place one in those guys. And it's the method of collection for a prostatic wash sample. Now, the gold standard method of collecting urine is a cystocentesis. It's done conscious, it's easily done by your vet, and this is perfect for all samples, including your culture, because there's minimal risk of contamination. It may just be contraindicated in coagulopathic patients. So if you do have any patients with severe bleeding disorders, we want to avoid popping a needle into the bladder. Okay, so we'll talk briefly on some common in-house tests. So when I was thinking about what tests to talk about, it made most sense to discuss pre-op blood work. So pretty much every practice will have their set pre-anaesthetic blood panel that they do for the majority of their patients. But do we know why we're doing it? So there's a few different things that tend to make up the majority of practices' pre-anaesthetic blood panel, and that's a PCV and total protein, blood glucose, blood urea nitrogen, and also creatinine. So they are just the minimum things that we should be doing. And if you have patients who have cost issues and we tend to run a full biochemistry and they can't afford it, you can just pick out some of these things, which will give you a lot more information on what you're dealing with. Now, if we run a packed cell volume, that tells us, we'll delve into all of these a little bit further on. But if we look at a PCV, for example, that tells us if it's low, there may be an anemia present. If it's high, there may be a hydration problem. So in combination with your total protein, if you have a high PCV and a high total protein, that may tell us that we're looking at a dehydrated patient. So maybe this patient needs fluids before we go putting it under anaesthetic. It's already dehydrated, and then we anaesthetize it without fluids. We need to be careful and be looking at those renal values. We don't want to tip these patients into renal problems. Blood glucose. So this is useful for hypo or hyperglycemia, particularly useful for your very young. So hypoglycemia can be common in puppies or very small patients. And a hyperglycemia, if you're maybe anaesthetizing an older patient, maybe for a dental or another procedure, we want to, if we see a hyperglycemia, we need to question, could it be diabetic? And do we need to stabilize this patient before we go along with the procedure? And then we have BUN and creatinine. So this tells us quite a lot about our renal disease. It can tell us about a few other things, which we're going to talk about a little bit later on. But they are really useful. If we have it and we know that it's normal, we know that we have a little bit more of a safety barrier before we go and anaesthetize our patients. Okay, so the normal PCV for a dog, 34 to 55, but the normal PCV for a cat is 27 to 45. So that's significantly lower than that of the dog. And I work in a referral hospital, and occasionally we have had cats referred to us for anemia. And when we've run the PCV, it's 27 or 28. And that's because people tend to remember the canine values, but don't always remember the feline values. And that is totally normal for a cat. If that were to be a dog, it wouldn't be. But it's important that we do remember the differences, and the felines are naturally lower. And the total protein for both species is exactly the same, so 55 to 77. So when we run our PCV and total protein, it is vital that we do both together. We get a much more rounded picture if we do both together than doing either of them individually. They're both quick and cheap and easy to run, so we might as well make the most of that easy sample. So a low PCV and low total proteins could indicate blood loss. So if we have hemorrhage, that blood is just being lost. It's the fluid and it's also the red blood cells, so both of those lines will go down. We have a low PCV with a normal protein level, that could indicate anemia. So either our body isn't producing the red blood cells, the protein's absolutely fine, nothing wrong with the proteins, or maybe our body's destroying our red blood cells, something like immune-mediated hemolytic anemia, where the immune system starts to target and attack those red blood cells. So the blood cells are going down, but the proteins are totally normal. So that tells us it's likely to be an anemia. And then a high PCV and a high total protein, dehydration. Rehydrate these patients, run it again, and it should have gone down. Now, I need a quick message to point out is cats tend to cope a lot better with anemia, and they often present with much lower PCVs than the dogs do. And quite often they can come in with a PCV, the lowest I've seen is 6 in a cat, and they're still sat up, they're conscious, a little bit tachypneic. But if a dog were to present with anything less than 10, it would be severely dyspneic and pretty collapsed. The cats do tend to cope a little bit better. And that may just be because for a cat to get from 27 to 7, that's a much smaller drop than to get a dog from 34 or 35 down to 7. So they'll have lost a lot more of those red blood cells. So it's just a bigger jump for the dog. And it's quite common that we see anemias in cats secondary to other diseases. We know that they definitely can get it secondary to renal disease because of the lack of erythropoietin that's produced by the kidneys, which stimulates the bone marrow to produce those red blood cells. If we have renal damage, our kidneys may not produce the erythropoietin, and then we start to see the effect in the anemia. But also secondary to many other conditions, cats have very sensitive bone marrow. So if they do have other conditions, it can quite easily become overwhelmed, and you might start to see quite a low anemia with these patients. And if you do see any abnormal blood results, so maybe we do have a low PCV, then we should always be making a blood smear. Ideally, have a look at it in-house. You won't get used to blood smears unless you start looking at the normal ones, and then you can start to look at the abnormal. And always send one externally. Okay, so when we're looking at blood glucose, we will have all done this so many times, so I'm not going to teach you how to do it, but there's just a few things to point out. And one of the important parts is that these blood glucose monitors are calibrated for capillary samples. So ideally, we need to be taking the sample from a capillary. And you can see here on the right, there's a picture of the sweet spot just on the pinner of the cat's ear. And if you don't always take it from a capillary, then the most important thing that we do is that we're consistent with our collection. So don't take a sample from the jugular vessel, then take it from the capillary, then take it from a peripheral vessel, because I've seen changes of up to 5 millimoles per litre just from changing the site. So if you're going to start taking it from a jugular sample, stay with a jugular sample, and each time just repeat from that same from the same sample site. It doesn't have to be the same vein. You can go the other side, but it should always be from a central vein or a peripheral vein if that's what you've started with. And if you do change site, then it's important to just note that on the patient's record, because if there is a big jump, then we know actually it could well be because we've changed the site and now we're going to start taking it from the capillary. Now, if you use the Lancet, these Alpha Track 2 are ideal for diabetic patients. They can be bought on Amazon for about £90, and they're the only ones that are actually calibrated for veterinary use. So they're much more accurate. The Lancets that come with these are really good. They're less traumatic to the patients, and they get a really good blob of blood. And if you can shave the ear just a tiny amount, that would help a little bit, but you don't have to. If you just smear a little bit of Vaseline over the area before you do it, put some warm cotton wool underneath, and then use the Lancet on top, then the Vaseline just causes a little bubble of blood rather than it absorbing across the skin of the ear and into the fur. It just kind of brings up that blood, so you'll get a little blob on top, and then you can utilize your Alpha Track there as well. And it is ideal for the majority of diabetic patients, but just be cautious with, if any patients are really nervous and really head shy, then you don't have to go on the ear, you can go on the gum, and you can also go on the paw pad as well, which seems to be tolerated quite easily and quite well. Okay, so albumin. So albumin is quite a useful thing to know about, but it's something that we often don't necessarily look for in our patients. So albumin is it's our biggest protein within the vascular system, and it makes up 35 to 50% of our total plasma proteins. So if we have a decrease in our proteins, maybe in our total protein that we ran alongside our PCV, the chances are the albumin is probably affected because it makes up such a big proportion of our proteins. Now, if we have albumin loss or hypoproteinemia, just meaning low protein, then there's a couple of areas where this could be coming from. Now, it's important to remember that the albumin is synthesized in the hepatocytes, which is the liver cells, and liver dysfunction can certainly be one of those conditions that can cause a decrease in the albumin level. We can also see it with renal disease, so we know that our kidneys shouldn't be losing protein. We shouldn't be allowing that protein to escape. We should be keeping it within the vascular system and retaining it within the body. But if we have renal disease, we may well start to see some proteins slip through that net, and we may start to lose them. So that's certainly another thing for the list. Burns, which luckily we don't see commonly in veterinary practice, but if you do, then the sebum that leaks out on the skin, that contains a high level of protein. So quite often you will see a low protein level with burns. And also increased gastrointestinal losses. So maybe we have a patient with IBD and we're starting to lose our proteins into that gastrointestinal lumen, and it's just being taken out with our feces. So some of these GI conditions can cause quite a severe hypoalbuminemia, and you might start to see patients with puffy legs or edematous face, and that's the typical hallmark sign of a patient who has a low albumin. And then finally, it's important to point out that albumin, being one of our large proteins, is the protein which maintains that colloidal osmotic pressure within the vascular system. So what that means is it maintains that colloidal pull. So when your proteins are within your vascular system, which is where they should be, it draws all of the fluid into the vascular system. So when they start to go low, then you may also start to see the fluids leaking out as well, because that osmotic pull has decreased. And that could happen with an increased vascular permeability. So maybe we have FIP, maybe we have systemic inflammatory response syndrome, or SIRS. So this just all causes a vasculitis or an increase in our vascular permeability. So we almost get leaky vessels, and then the proteins leak out and it can take the fluid with it. So they're quite useful to know about if you do have a patient who comes in with peripheral edema or edema around the face. Check the albumin and see what's going on. And also, if you're aware that causes the colloidal osmotic pressure, check the blood pressure as well, because if we are leaking out our proteins into the peripheral spaces, then our blood pressure may also drop as well. So it's good practice to check the patient's blood pressure in these conditions. Okay, so we have lactate. So lactate is relatively new. It's been around for maybe 10, 12 years. But do we use it actively in practice? And if we do we know what we're looking at? So it can be quite complicated to explain why it's produced. So hypoxia, it can be produced from hypoxia. So when we have hypoxia, it could be either from a true hypoxia, so maybe the patient does have some respiratory issues, or maybe it could be from hypoperfusion. So maybe our oxygen level is perfectly fine, but we're not perfusing those cells, and we're not allowing that oxygen to reach those cells. That could be things like dehydration, or maybe the patient has a cardiac issue, so the oxygen level is fine, but the pump is not achieving what it should, so the heart is not pumping effectively, and it's therefore not perfusing that oxygen around to those tissues. So when our body has a level of hypoxia, we start to go through a cascade of events. So our body requires oxygen on a daily basis, so we're classed as anaerobic. We're classed as aerobic. So we have aerobic metabolism on a daily basis, but when that oxygen is depleted, we need to do something about it, because our cells could start to die if they don't have oxygen. And the thing that we start to do is we start to convert some of those tissues and some of these areas to an anaerobic state, just to allow it to survive that little bit longer for if this oxygen doesn't return. And it just goes through a cascade of events. So one of those events is the production of lactic acid or lactate. If you do see a hypoxia occur, then you will quite often see an increase in your lactate. So it could be from hypoxia or perfusion. They're the two most common things. And an elevated lactate is classed as anything above 2.5 millimoles per litre. Now, as you can imagine, this is quite a strenuous task to convert your body and to do all of these things. So it requires a lot of energy, and it has quite a high metabolic rate. So we start to use up our glucose. So as your lactate increases, run a blood glucose and just check it alongside, because you may well start to see that the blood glucose is going down with the more severe cases. And that's just because we have that metabolic demand, and we need that energy to convert our body to try and cope in this whatever state the patient is in, and to try and convert our body into an anaerobic state, if that makes sense. I hope it does. And because lactic acid is an acid, we may also start to see an acidosis form. So if we run an EPOC or an electrolyte panel that usually has your blood gases on there, then we may start to see a drop in our pH along with an increase in the lactate. So we used to say if your lactate is above 10, it means pretty much game over for the patient, but it doesn't mean that anymore. So what we tend to say is, yes, the higher the number, the more severe the problem, but the important thing is it coming down with treatment? So if you put this patient on fluids, or you start to treat whatever it is that's causing this, and the lactate then, when you repeat the sample, maybe half an hour or an hour later, is not budging, that's when we start to ring alarm bells. So if it is coming down, and maybe we've increased our patient's perfusion, so our oxygen is being nicely perfused to those tissues now, then that lactate should start to decrease. And if it does, that's great, and it's a great way to monitor the response to your treatment. Is your fluid therapy high enough? It's not just that the patient is not responding, it may be something that actually we need to treat it more aggressively. So it's a great tool to have, and particularly in our really sick patient. It could also be, we quite commonly see this in the GDV. So if we have an organ like the stomach which is twisted and cut off the blood supply, that's a hypoxia to the stomach. So you will quite often see a really high lactate above 10 with a GDV patient. Okay, so I work in internal medicine, and one of the most common electrolyte abnormalities that we see is potassium. So we see many patients with vomiting and diarrhea, and when you vomit or you have diarrhea, you lose your electrolytes in that vomit and diarrhea. So quite often they'll come in with a low potassium value. So one of the questions that I always used to ask is, if a vomiting and diarrhea patient has been admitted, yet we run the sample and it's normal, so normal is 3.5 to 5.5, and say the patient's potassium value is 3.5, why do we still put them on potassium? So the reason for that is because potassium is renally excreted. So as soon as we put our patients on fluids, it may be just about maintaining the normal level for now. As soon as we put our patients on fluids, we're going to promote diuresis in the kidneys, and our patient's going to start urinating more just because it's on fluids. So therefore, our potassium value is suddenly about to drop. So that's why we tend to still put them on a maintenance potassium value, and that's just 20 millimoles per litre, even if our value is 3.5, if our patient has losses like vomiting and diarrhea. Now, a serum potassium value below 2 millimoles per litre can cause muscle weakness, and this can include the respiratory muscles and anorexia. And hypokalemia should be supplemented ideally by spiking the bag of fluids according to its potassium level. Now, if we do spike these fluids, then we should not ever flush these lines or bolus them. So if we have a dehydrated patient, even if we're worried about potassium value, we should hydrate them first with fluid boluses. Then once we're happy that their dehydration or their shock is under control, then we can start introducing, with the maintenance rates, we can start putting potassium spike fluids on then. So if we bolus potassium too quickly, it can cause cardiac arrhythmias, bradycardia, and also cardiac arrest. So it's important that we have little stickers which we put next to the IV catheter line. I think we have a picture on the next slide. And they just go down the line, and it can go next to the port, and it just says do not flush. And that's just really important message to just make somebody stop and second guess what they're about to put down that line and why they shouldn't be flushing in. Because whether it's flush, whether they're given some paracetamol, whether they're given an antibiotic, it should not go down that line. So ideally have a T connector with a second port on the IV catheter, and you can use that second port for any fluid boluses or drug boluses. Now, if you do spike the patient's bag, then we should ideally be checking our potassium value again, reassessing it at least ideally every 24 hours. And if the supplementation is above 60 millimoles per litre, which is relatively high, then we should be rechecking that twice a day. And when you do bolus these bags, when you put the drug in, just make sure that you're mixing that bag thoroughly. So we invert it 4 times as a set protocol before we will link it up. Because the last thing we want is a little bubble of potassium sat next to that port as we're about to start the fluids running through. Okay, so yeah, you can see here that's the label I was talking about, do not flush, just next to the port, which is really useful. And you can just buy these labels quite easily from some of the veterinary suppliers, and you can write on it what you like. You can get all different drugs and many different things. So this do not flush is a really great tip. So we may also see the opposite of a hypokalemia. So we may see a high potassium value. So potassium is one of the main electrolytes managed by fluid therapy. And therefore, if we have a hypokalemia or a high value, then fluid therapy is usually our first port of call to bring that down. Now, it depends on the level of the hypokalemia as to whether we just put them on fluids or whether we treat with drugs as well. So there could be many different things that can cause a hypokalemia. Your blocked cat is one of the common ones that we see, because that urinary obstruction is not allowing the body to excrete that potassium, so it's building up. And usually, even though it is quite high, once we empty that bladder and get rid of that obstruction, it's likely to start coming down. However, depending on how high it is, we may still need to give therapy for it. And hypokalemia can be acute in onset. We can see normokalemic patients, or we can also see hypokalemic patients who tend to be chronic renal diseases if we're talking about kidney disease. And if the potassium value is above 7 or 7.5, then we tend to give insulin, and we need to give this alongside glucose, because we know that when we give insulin, our glucose is lowered. That's why we give them to our diabetic patient. Glucose is also a co-transporter of potassium, so it sends both of those electrolytes into the cells. So if we give this to decrease our potassium value, it will also decrease our glucose. So we need to make sure we're monitoring and supplementing the glucose alongside. And we can also see cardiac arrhythmias or bradycardia. So if you have a cat in with a bradycardia, say maybe 100, which is quite low for a cat, 100 beats per minute heart rate, then we need to start to think, right, this potassium is affecting the heart. And we can see bradycardia, arrhythmias, and tall spiked T waves on your ECG is the hallmark sign. And usually they're about 2 to 3 times the size of the QRS complex. So if it's just mildly increased, it's unlikely to be relevant, but it should be at least double or 3 times the size of that QRS. It's really tall, and that's likely to be from your hyperkalemia, quite commonly seen in your block cats. Now, if it is causing cardiac issues, we can give calcium gluconate. Now, calcium gluconate can be given IV, has to be given slow, over 2 minutes, and the dose is 0.5 to 1 milligram to 1 mil per kilo. And this just blocks the cardiogenic effects of the hyperkalemia, but it does not decrease the serum potassium value. It will protect the heart, but you'll still have a hyperkalemia, and that's why you need your insulin alongside and your fluid therapy. Okay, so samples which require immediate processing. These are the samples that you take and you run. You have to run straight down the corridor to the lab and get them run as soon as possible. So arterial blood gas, I don't know if many of you take many arterial samples, but if you ever do, or if you're working with somebody who does, then that needs to be run straight away. The longer that sample is out in the environment, the longer the environmental oxygen will alter the O2 results. And then it defeats the point of doing an arterial sample. You could have just got a vascular sample. If you want an accurate result, you need to run to the lab. Also, potassium and lactate, these gradually increase in samples if they're left over 2 hours in the lab. And ionized calcium, ammonia, glucose and insulin assays, these are all things that need to be run pretty quickly. Now, ammonia, this is something that we might test for in our, maybe we have a liver patient, liver disease, or maybe we have a portosystemic shunt with neurological signs. So if we test our ammonia, as that warms up to room temperature, that value will start to decrease. So with these, we tend to keep a few different blood tubes in the freezer. And then as you take them out, it's already cold. It's ideal for these samples. And then you can just sit them on a block of ice while you're getting the sample and running it to the lab. And it just prevents any warmth getting to that sample, warming it up and potentially giving our patient a false result, which was within the normal limit. And then that would delay treatment and it will be detrimental for our patient. So all of these little things that we do can really help how our patient receives the care. And also glucose, if you're taking a sample for glucose, those red blood cells are alive within that blood tube. So we know that we metabolize glucose as an energy source, and that's what glucose is in our vascular system for. If that's sat in the lab for hours on end, those live red blood cells are metabolizing that glucose. And if you're running something like a glucose with an insulin assay, maybe you're checking for an insulinoma, then we need to make sure that this is as accurate as possible. So just spin it down as soon as you can and get that dealt with straight away. Okay, so we'll talk a little bit about renal and hepatic values. So we'll talk a little bit about azotemia. And the definition of this is just abnormal levels of nitrogenous waste products in the bloodstream, i.e. your urea and your creatinine. So if you have elevations in urea and creatinine, that means your patient is azotemic. So when we're thinking about azotemia, we need to think of the origin. Is it pre-renal, meaning before the kidney? Is it renal in origin? So is it actually coming from the kidney itself? Or is it post-renal? And we'll talk about what those three mean. So a pre-renal azotemia is likely to be from hypoperfusion. So maybe the kidneys aren't being perfused like they should. So that could be things like dehydration, shock, congestive heart failure, or maybe hemorrhage. So if we have dehydration, our renal values are likely to increase. They're not usually really, really high, but they can increase enough to flag it on our renal values on our blood test. And if this is maybe a young patient, it's not a patient that we're suspecting kidney disease, there are other things that we can do to just check, is this pre-renal? Maybe something quick, easy, cheap, run a urine specific gravity. If they're dehydrated, it should be concentrated. If it's not, and it's dilute, then maybe with dehydration, maybe we do have some renal issues there, and that does correlate with some renal disease. So there's a few different things that we can use to check this. And we can also run our PCV and fetal protein. Are they both elevated? Is this looking like a dehydration? Or next, is it renal in origin? So is it within the kidney itself? So maybe we have an acute kidney injury. Maybe we have chronic kidney disease or any other renal disease itself. And then finally, we can have post-renal. So this just means anything that's after the kidney. So this can commonly be things like urinary tract obstruction. Maybe your blocked cat, your blocked dog, or urinary tract leakage. Maybe we have a ruptured bladder. Maybe the patient's been involved in a road traffic accident. And this is where we tend to see, in a lot of those post-renal cases, we tend to see a high potassium value alongside the increase in our renal values. And that can be one of the signs that we can test alongside just to see what else is going on. Okay, so BUN, or blood urea nitrogen, what does it mean? So this is an end waste product. And when we have the metabolism of amino acids, breaks down ammonia. Ammonia is a toxin. It's a waste product that we do not want in our body. The ammonia is taken to the liver, where it's converted into urea. So urea flows then to the kidneys, and then that's where half of the urea is excreted. So our renal function is assessed based on the kidney's ability to remove this waste product from the circulation. So if we have renal damage or something else going on that's affecting the kidneys, we may start to see an increase in that urea because they're not able to excrete it properly. And if the renal function is impaired, or maybe if it is something like dehydration, maybe that waste product just isn't being taken to the kidneys in order for it to be excreted. And that's why you might start to see it mildly elevated with dehydration. Okay, so creatinine is found in skeletal muscles, and it's formed as part of muscle metabolism. So once our muscles are being metabolized, then this just enters the different bodily fluids via diffusion. And that's just as we have muscle metabolism going on, maybe from exercise, from those muscle cells. And therefore, the total volume of creatinine within the bloodstream reflects the amount of muscle mass that we have. So you can see here in the background, I have a picture of a greyhound. So they have a really high muscle mass, and they have a high metabolic muscle rate as well. So they have a naturally elevated creatinine level because it has to reflect the amount of muscle that they have in their body, because that's where creatinine comes from. It comes from the muscles. But then if you think of it the other way, so if we have a really underweight cat, maybe we have a kidney disease, chronic kidney disease patient, if they have a really low muscle mass, then the creatinine will also reflect that. So in these patients, we need to interpret these results carefully, because we could have an underweight, emaciated cat with really low muscle mass who has chronic kidney disease, but the muscle mass is that low that it actually appears that the creatinine is normal on the blood value. Now, if we have an underweight cat who has barely any muscle, it shouldn't have a normal creatinine, it should be low. And if it isn't, then we need to start thinking, actually, this cat might have kidney disease. And in those cases, we tend to see it back after treatment, and once it's gained a lot of the muscle mass, maybe it's on a renal diet, and it's a much better bodily condition, then repeat those blood tests and see where that creatinine is sat, because it will then reflect a healthy body weight and a healthy muscle mass, and that's when you may then start to see an increase in that creatinine value and a true chronic kidney disease starting to show. Okay, so liver cells or liver enzymes. So when we look at liver cells or liver enzymes, we look at the liver can work in compartments. So the whole organ doesn't have to be damaged. It can be functioning perfectly fine, but we may just have some areas or compartments which are damaged. And the liver cells can regenerate from damage, which is a really important message to remember. And we have a few different liver enzymes. So one of them, which we'll go into a little bit more depth on the next slide, is ALT. And this is an enzyme that's released with hepatocellular damage, so liver cell damage. So maybe we have a tumour, some form of neoplasia. Maybe we've had a toxin that damages the kidney. Or maybe the liver, or maybe the patient has been hit by a car and we've had a blunt force trauma. So if we have destruction or damage to those liver cells, your ALT will increase. But the blood level of the ALT does not correlate with the severity of the disease. So say this patient was a trauma patient, it may have a really sky-high ALT because it's been hit by a car and it's caused loads of liver damage. That doesn't mean that actually in a few days' time or in a week, that ALT could be back to normal. So even though it's sky high, it doesn't mean that it's non-repairable, and it doesn't mean that it's really severe disease. It just means that it's had damage and it's repaired itself. Don't let that put you off when you see that. It doesn't mean that it can't be fixed. And ALP, this tends to be elevated with things like cholestasis. So cholestasis just means anything that causes the blockage or the slowing down of the flow of bile through the liver. So pancreatitis can slow that down because of the inflammation around the liver and the pancreas, and also a cololith, so a gallstone. If there's a gallstone there, then it will block the bile duct, and you might start to see an increase in your ALP along with other enzymes as well, like your bilirubin. And ALP is also an isoenzyme in dogs due to excess glucocorticoids. So if you have a patient who is Cushingoid, who naturally secretes an increased level of glucocorticoid, or maybe you have a skin patient who's on prednisolone, they're on steroids long term, then the machine will read the steroids as ALP because it's made up of the same isoenzyme. So if you have a patient on steroids, always interpret the ALP cautiously because it's likely to be caused by the steroids rather than the liver itself. Now, neither of these tests tell us anything about liver function, so it could be functioning perfectly fine. These are just different enzymes that tell you about, maybe point to different areas. And in cats, even mild liver enzyme elevations are important, and that's because, this says it on the next next slide. No, it's in a moment. So liver enzymes for cats have a really short half-life. So it's about 3.5 hours, whereas the half-life of liver enzymes in a dog can be about 70 hours. So what that means is if a cat has an increase in the liver enzymes, they will, if the problem is not going on, it wouldn't have had it, it won't still have it on the bloods, it will have gone because the liver disease is gone and the body's metabolized it. So if those liver enzymes are increased, it means that there is a problem going on right now. Whereas a dog, it could have been 4 days ago. So we do need to act a little bit quicker when we're looking at liver enzymes in cats. And that's just one thing to just bear in mind for if you do see it on a cat's biochemistry results versus a dog. And then we'll talk a little bit about bilirubin. So this is a molecule that's derived from the breakdown of your red blood cells, mainly the hemoglobin that's contained within the blood cells. It's metabolized in the liver, and then it becomes part of the bile. So we know that once bilirubin or bile is in the gallbladder, when the patient eats, the gallbladder contracts and it sends that bile out and into the duodenum via the common bile duct. So that just coats the food. It then starts to metabolize and break down the food, and it's excreted in the feces. So we may start to see high levels of bilirubin in our bloodstream, which can cause jaundice, and this can be caused from conditions such as a blocked bile duct. So if we have a blocked bile duct, it's not able to escape, and therefore it builds up and we become jaundiced. Maybe we have hepatocellular dysfunction, so our liver cells aren't working properly and aren't able to metabolize that bilirubin. So we start to see a buildup. Or it could be an excess in our red blood cell destruction. So we've just said that bilirubin is increased as a result of red blood cells breaking down in the spleen and releasing that hemoglobin into the bloodstream. So this happens on a daily basis, but it's a nice normal level that we can keep on top of and that we can maintain. But if we have an excess in our red blood cell destruction, we're releasing a lot of hemoglobin into the bloodstream, and then we will start to see jaundice. And it's important to remember that jaundice stains the blood. So even if we do have a patient, say, does have IMHA, and we start to treat the patient, even though the patient is being treated perfectly well and it's responding well, this jaundice is likely to stay for a couple of weeks or months because it stains the blood cell, it stains the tissues. So it's important to make the owners aware not to use jaundice as a response to therapy. To don't think it's not being treated well because there's still jaundice, because it's just stained, then it will go. Okay, so ALT, we have touched on this briefly, but this is a marker of hepatocellular damage. And there are a few causes that could cause an increase in ALT. That could be endocrine disease, so diabetes. It could be inflammation, like pancreatitis. It could be a trauma, or it could be things like your maybe different drugs, so xylitol toxicity or blue-green algae. Then we'll talk briefly on urine analysis. There's not much to this bit. So urine-specific gravity is something that we do in-house every day. So the one thing I want to point out about specific gravity is that it should always be assessed alongside hydration status. So we know that if we have a dehydrated patient, our specific gravity should be high because it should be concentrated. We have really concentrated urine when we're dehydrated. So if we run a USG and it's within the normal limit and it's not concentrated, then that's why it's so important to look at that hydration status, because actually, yes, it may be within the values, but that's not normal, that's abnormal. So that tells us that our kidneys aren't concentrating like it should be, because that should be a high value in correlation with the hydration status. And always remember to get the specific gravity sample, ideally before we put our patients on fluid therapy, because this will automatically promote diuresis and it will start to dilute our urine because of the fluid therapy, so it won't be as accurate. And there are inappropriate concentrations that come along with different conditions. So if we have a patient on prednisolone steroid therapy with PUPD, we may see alterations in those results. It may be low. Cushing's disease causes really severe PUPD, so we may well see a low value with that. And the same with pyometritis or hypothyroidism. Now, when we're looking at sending off urine to the lab, when you spin down the Eppendorf tube, so when you've taken off your sediment, you've looked at it under the microscope, you will have a really concentrated small sample left in the bottom of that tube. Use your culture swab and just mop up the rest of what's in that Eppendorf tube. It's the most concentrated, it's full of bacteria if there is any, and that's going to give you the most accurate culture result. And also, if you have a pH monitor like this, the red one that we have on the side here, try and utilize it as much as you can in practice, because if we're looking at urine in particular, this tells us a lot about what could be causing the condition. So certain urinary crystals, for example, will only be present with an acidic urine, whereas others may only be present with an alkaline urine. So it actually gives us a fair bit of information, and it allows us to rule out certain diseases as well. So it's a really useful thing that we can use in-house. And then if we are sending off any urine, maybe we've made up a few slides and we're going to send them to the lab, or maybe we're looking at blood smears. Just one message to say about when we're packaging them and we're sending them off is they should not be stored anywhere near formalin. So even if you've just put a few drops into a sample just to fix it, into your urine or into any other sample, we shouldn't be storing that next to any slides or any smears, because it can start to affect the cells. When you send them to the lab, they may not be as accurate. So even if you put one in cotton wool and the other in cotton wool, but yet still in the same pack, that will still go through the layers of cotton wool. So they should ideally be one's in one box and one's in another box in another area. So bear that in mind if you do have some important smears there, and then you've sat it next to formalin. Okay, so just a short few slides on blood smears. So blood smears are really important in-house and also for sending off. So these are something that we do in our OSCEs, and it's variable as to whether people continue to do them in practice. If there's any hematology samples going off to the lab, you should never send them without a fresh blood smear. Ideally straight from the syringe without even being in the blood tube. But even if it's being in your EDTA, still perfect, do a blood smear. And that just allows the lab to get the most accurate, fresh results before sending it off and before it's been stored in a blood tube where it can change. And also, if you see any abnormalities with the likes of your PCV or any other cell counts in-house, do a blood smear and have a little look. The more you look, the better you'll get. And practice makes perfect. So we might look at a blood smear for white blood cells, we might look at a platelet count, or we might be looking at our red blood cells. So with anemic patients, their blood is a little bit more watery. So if you have a wider angle between the slides, then you tend to get a nice smear. Because it's quite watery, it will often run off the edge of the smear and you won't get your feathered edge. So just increase your angle and you'll get a nice feathered edge there. And then the opposite with your hemoconcentrated patients. So if a patient's really dehydrated or has a really high PCV, their blood's likely to be a little bit thicker. So just narrow that angle and then you'll get a longer smear when you're doing your, when you're running the slide across. So these are vital for any forms of anemia, especially IMHA, because you need to examine a blood smear under the microscope in order to diagnose IMHA, and practice makes perfect. Even if you go through loads of different slides, you've emptied the box completely, at least you're practicing, and then the next time you look at it under the microscope, you will be that step better, because no one will improve if they don't keep repeating what they're doing and keep on trying. Now, this might seem really, really simple, so apologies if it is, but just a few things that I wanted to put in here here because they really bug me when I see somebody do it in practice. So just to explain the areas of the blood smear, so you have your thick area at the bottom. If you can see my mouse, no, I don't think you can. There. So thick area down here. So we don't tend to look at that area. It's this area that we'll look at, and also the feathered edge. So you should have a good area on your slides, which is just one cell layer thick. And this is where we'll do a lot of the counts if we're looking at red blood cells. And then you should have a nice curved feathered edge here. And this is where some of the white blood cells or your platelets might go to. So it's important that we have this one cell layer thick and then the feathered edge at the end, because otherwise we can't really interpret what we're looking at. And always write in pencil. So the amount of times I see people write in Sharpie or even in pen. So when you send these off to the lab, they receive hundreds of samples, hundreds of slides every day. They have to just submerge the entire slide into the stain, and it goes away, and it will stain the slide. So you will then pull the slide out, and the Sharpie has spread across into the stain, probably ruined it, but you'll also then have a blank slide. So that's quite dangerous. You may not get results back for that patient. But also it will leak out, and it is likely to just damage the stain rather than giving you any producive results. And it may also go on to stain your cells as well. So always write in pencil. It doesn't come off in the stain, and just keep one in lab, which you can use for all of your smears. And if you see anybody doing it, tell them off. And then down at the bottom, I've written the name, and then always label the slides with what it actually is. So the amount of times you might see somebody doing a liver FNA, which is just blood. So they'll do a load of smears, send it to the lab, and it just looks like a load of blood smears. They don't know it's actually from the liver. So always label the slides with what it actually is. Where has that blood come from? So they can look very similar. So it's important to identify so that the lab know exactly what they're looking at. And then I've just put in a quick reference guide. So these are just some of the normal laboratory values for our patients. So PCV, total protein. The one that's on there that I haven't discussed is pH. So your blood pH should be anything between 7.35 and 7.45. If it's any less than that, it's acidic. If it's any more than that, it's alkaline. And it is useful to look at that alongside some other results. We don't have time, unfortunately, to talk about it in this slide. Blood gas analysis is a whole different lecture of its own, but it is quite useful if you can start getting used to the normal values and start looking at your blood results. Because yes, as RVNs, we're not allowed to diagnose, but we can certainly understand what's going on with our patients. And if we look at those samples as they're coming out, those results, then we can act on them quickly and really make a difference to our patient care within the hospital, especially if those patients are sick. So start looking at them, start interpreting them, and even if you take a picture of one of the results, if you're not sure of it and your vet's busy, and then ask them about it at the end of clinic when it's a quieter time. They might have time to go through the results. You don't have to tell them what you thought, just ask them what the diagnosis was or what they thought of those bloods, and test yourself until your confidence starts to build that actually you do know what's going on. And then you can start having open discussions about these things, because we're not just lab technicians to just run the samples. We play an important part in the whole picture for our patients, and it's our job to try and improve our interpretation skills so that we can be there for our patients when they need us. Okay, so that's it from me. If you do like internal medicine, I do have a Facebook and Instagram page. It's called Veterinary Nurse Medicine Geek. So please follow me if you do have social media. And otherwise, I hope you've enjoyed the talk.
Okay, thank you very, very much, Sophie, for that really, really informative talk on lab. I've really, really enjoyed that, and yeah, lots of little snippets to try and get your brain thinking all over again. So if anyone has any questions, answer box or the Q&A box at the bottom of the screen. So if you want to type in there and then send them on over to Sophie, we can put a few questions to her. So we'll just give you a couple of little minutes just to see if anyone does have any questions before I let everyone go.
The thunder's just started, just in the nick of time, just for me.
Oh gosh!
The connection doesn't go too early.
See, it was holding off for you, just waiting, waiting until we got to this slide. Well, there's nothing come through as yet, Sophie. So I think you may be off the hook there a little bit, and you can go and go and get yourself all settled down with a cup of tea this evening. So thank you again for a really, really interesting talk, and I really, really enjoyed that, and I hope everyone else did, and I hope it's something that everyone can take back to practice and